Well, hello everybody. We were waiting for the latecomers, but I think we're going to get it started. Otherwise, it's going to be difficult. My name is Sonia Feldhoff from ABC Radio Adelaide. It's great to see you all out tonight. Hope a few more people will arrive as we get started. I imagine they're having a few parking problems. I want to start, if I can, by just acknowledging that we are meeting tonight on Kaurna land, and we pay our respects to elders past, present and emerging. So it's always a nice way to start the evening. It's great to see you all here. Now, I don't know why you're here tonight. I presume you want to get more information about this very important stage of life. I think we've done 3 of these now, these forums in association, I should say, with the Multicultural Communities Council of South Australia, Dr. Jane Elliott. We're into our 3rd one, and it's always been incredible. This is an area that I have interested in, and every time I've come, I have learned more and more. So you're going to get a lot of information tonight. A lot of good, reliable information, and you're going to have a chance later to answer some of the questions that you may have about things that perhaps aren't addressed or things that you want to get more information on. So there will be an opportunity before we finish tonight for you to ask those questions. So be thinking about them, be prepared for that, because it will only be a short period of time. So sometimes people get a bit shy, and it'd be good to start thinking about those things now if we can. Tonight you're going to hear from Dr. Jane Elliott. Now, she is a GP, she is many other things, but in her course of her work as a GP, she decided to focus on women's health, and thank God she did, is all I can say. She has focused on many things associated with women's health, including menopause, and so she has a whole huge amount of information around that. She is also someone who teaches medical students through the course of her lecturing, and you may be well aware that in the past 12 months, while menopause is something that we haven't really, I think, in many ways spoken a lot about, in recent years that has started to change, and in the last 12 months we've seen a parliamentary inquiry into menopause, and that has already reported to Parliament with 25 recommendations. Now, South Australian Senator Marielle Smith was the co-author of that report, along with Green Senator Larissa Waters. And Marielle was hoping to be with us tonight. Unfortunately, her diary meant that she is in fact flying back from Darwin as we speak. But she did organise with me to catch up to talk about the outcome of that inquiry. So you will get a few minutes with her at the end of this session as well to find out what is being done on a federal level to try to perhaps change some of the things that mean you may not have been treated and other women may not have been treated as well as they perhaps could have been in relation to menopause. So plenty coming up this evening. We'd like to get started though by thanking Aware Women's Health, with whom Dr. Jane Elliott is associated. ABC Radio Adelaide, my organisation, has obviously been a support for this as well. The driver of this is the Multicultural Communities Council of South Australia, thanks to the lovely work of Helena Kyriazopoulos. The National Council of Women, Jean Hales, remember that name because that is a great resource for fabulous information if you are looking for that around menopause. Soroptimist and BPW Adelaide. We thank all of these organisations for coming together to make sure you get good, reliable information around menopause. Now, to get started, I guess you may well have already started this journey into menopause or perimenopause. You may well have known people who are. Maybe you just want to be prepared, and good on you if you are just getting organised to be prepared on this front, because we all have a different experience. Now, Jane will bring you the figures, but there are a whole lot of women who go through this menopause journey with very little to show for it in terms of symptoms. Then on the other hand, there's a small group of women who experience it really, really extremely, and then there's the rest of us in between who have a varying range of experience of the symptoms of menopause. So we are going to be talking about that, but it's really good to actually hear from someone about their experience, and we're going to do that tonight with Cherie Lee. Cherie, come up if you can. So it's good to talk with you, and thank you for coming here, because it's hard to talk about your personal experience sometimes. Cherie, what did you know about perimenopause and menopause before the symptoms started to take hold?
Absolutely nothing. All I know is my mother used to say, one day you'll go through the change of life and you'll get hot flushes. I never had a hot flush, so I wasn't prepared for the journey that I began a year ago.
What were the signs for you that things were changing in your day-to-day life?
First of all was the joint and muscle pain and the fatigue. They were the major ones for me that I struggled with for many years.
And when you talk about muscle pain and fatigue, describe it. I mean, we're all feeling tired, we're all harried, we're all busy. What do you mean by that?
So I thought I needed a knee replacement, a hip replacement, my ankles kept giving in, I thought it was my shoes, my arch supports. So it was just debilitating to the point where it caused lots of bursitis and tendonitis in my hips. My whole body was inflamed, like I woke up with the flu every single day. So mine were pretty severe.
It got to the point where you didn't think you could get out of bed?
No. So a year ago, the symptoms hit me so hard where every day was a struggle just to get out of my bed. I would crawl out of the bed, I would go to my couch, I would sit down and I would think, how in the hell am I going to go to work today? How am I going to get in the car and drive today?
And what's your job?
I'm an early childhood worker.
Oh, right. So you don't need a lot of energy for that, do you?
So for me to hop in the car and go to work, and there were stairs at my work in the playground, and I would literally have to hold the railing and climb up those stairs, and my work colleagues would look at me and think, are you okay? Is everything okay? And I said, I don't know what's wrong with me. I think I might have long COVID, or it's menopause, I don't know. So for me, every day was a struggle just to leave the house.
So you went to doctors, presumably? You had tests, you had scans.
Yes,
what did they say?
Well, originally I went to a gynecologist probably when I was around 43 because I was having a lot of period pain. My periods were a bit all over the place. And I said to the gynecologist, could it be menopause? And she said, how old are you again? I said, back then, 43. Oh, no, you're way too young. You're way too young.
And that was from a gynecologist?
Yeah. Yeah. It wasn't until a friend of mine who's 37 who had early onset perimenopause and our symptoms aligned, and she said to me, it could be perimenopause. So I went to my GP, and she was my new GP at the time, and I said to her, my friend's going through this. I think I've got this as well. I need HRT. Could you please prescribe that to me? And she said, let's do the menopause symptom checker. We did that together and said, oh, absolutely, this looks like your perimenopause. She said, look, I don't really know much about this. I don't know much about HRT or the medication. So come back in a week's time and I'll speak to my colleagues and we'll see what we can do for you. So I went back in a week's time. She said, here's your prescription. Off you go. She muddled up the 2 weeks on, 2 weeks off with the progesterone, and she rang me about a week later and she said, I'm really sorry, but I've muddled up your days. I'm new to this and you're new to this, so it was a journey for both of us.
At least you had a doctor who was willing to try and look into it. I don't think that's been the experience of everybody. Yeah. When did you start noticing yourself feeling better, if you did?
So I was rubbing that estrogen gel all over my body thinking, wow, I'm going to feel amazing. And it was literally 2 or 3 days, and it was the Royal Adelaide show, and I was taking my daughter that day, and I thought, how in the hell am I going to get through this whole day at the show? I've got no energy, everything hurts. And I put that cream on, and I was just like a whole new person. I was bouncing around the show. I was, like, woo! So
it was that quick?
It was that quick for me, yeah. Yeah.
And did that get rid of your symptoms or just to ease them?
It eased them, so obviously tweaking the medication over the past year to get it right, but it was pretty quick for me.
You've been talking and focusing on the joint pain because that was the worst symptom for you, but were you having other things?
What were the other things?
Brain fog, anything
night
like that?
sweats, brain fog, muscle, joint pain, anxiety, depression, thought that I'd have to give up my job. So it was pretty severe.
At your worst, were you considering changing your life choices around what was going on with you?
Yeah, we went house hunting. We were planning to downsize because I thought, well, I can't work, so we'll downsize and we'll sell the house, become, a bit more mortgage free and figure out.
But it was that severe, you were prepared to
Yeah.
make that bigger life choice? Yeah.
Tinnitus. Tinnitus, that just came to me. Yeah, so the tinnitus, I thought, why is the tinnitus getting really, really bad? So the ringing in the ears was really bad. That's
Right.
another weird symptom that I didn't know existed.
Yeah. Now, you're obviously on the road to recovery in terms of living a normal life again. What would have made things easier for you along the way?
Oh, just resources and knowledge and education and knowing more about this. I mean, it wasn't until my husband listened to a podcast with Louise Newson and he said, oh, I've just listened to this podcast. I think you need to listen to it. And I listened to that and it was life-changing. It changed everything for me.
Yeah.
All the anxiety disappeared, all the fear, the worry surrounding, the drugs, the HRT, all just vanished. So that was a huge turning point for me.
Because HRT, you were using it was helping your menopausal symptoms, but what, you were anxious about the perceived risks around it?
Absolutely. So I guess for me, it was the cancer risks that everyone was talking about, but that we don't live in our mother's era anymore. So as in that drug for them.
Well, Dr.
was-
Jane Elliott will, I'm sure, talk more about that because I think that is something that a lot of people feel,
Yeah.
but she will give you the full bottle on the risk and what the reality of that is. This has got to the point where your experience was so severe you wanted to help others, so you set up a Facebook support page and you run the Adelaide Perimenopausal Support Group. Are you hearing similar stories from people who are joining up there about their lack of help along this journey?
Absolutely. There's lots of questions asking which doctors help, which doctors can they go to for HRT, which doctors have the knowledge to help. We have lots of people with different symptoms, lots of people seeking different ways to treat their symptoms. So I'm finding now almost 600 members. It's been really wonderful for me and to help others.
Thank you for being open enough to share your story, Cherie. Cherie Lee, thank you so much.
Thanks for having me. Thank you.
Now that's Cherie's story. Each and every one of us probably have a slightly different version of that. And so there is lots to learn about that. So let's get on to the woman who can hopefully provide a lot of those answers. Through the course of tonight, you're not only going to hear from her, but you're going to hear from Sonia Scharfbillig. Now, she is a pelvic health physio, I should say. So she's going to give us some tips later in the evening as well. But first, let's talk about Dr. Jane Elliott. As I've told you, she is from Aware Women's Health. She's a clinical senior lecturer in the discipline of obstetrics and gynecology at the University of Adelaide. And we thank goodness for that time when she decided that she was going to specialise in women's health. Please put your hands together for Dr. Jane Elliott.
Thanks very much, Sonia. Can everybody hear me at the back, right up the back? You up? Yes, that's good. Thank you, Cherie Lee, first up, for telling your story. I think the sad thing is it's not that unusual a story, is it, as you would have found out, and I think this is the big problem, but I think it's fabulous that you're willing to tell that story. I hope that tonight we can at least give some information that might help some people a bit further down the track. And I'm going to specifically talk about what I call the old lady feeling, which is those joint aches and muscle pains. I'll reference that through this talk. So for some of you, this will be a refresher in biology, and for others right from the beginning. I'll go fairly quickly. I just think it's worth really understanding what menopause is all about before we go on to the actual treatments that might be possible. So what is menopause and why does it happen? We know that menopause is defined as somebody's last period, but it's really not really about the bleeding. You know, women who've had a hysterectomy still go through menopause. Women who are on the pill, who aren't having periods, go through menopause. So what menopause is really about are those two spotty structures on either side of the uterus there. Menopause is about the ovaries running out of eggs, or follicles as they're called, and the follicles are the areas in the body that produce estrogen. So menopause really happens when the ovaries run out of eggs and estrogen, and when that happens, you have your last period. So I am going to talk about other hormones tonight, but when you think about it, I've just told you what the treatment might be, because I've said that menopause is about running out of estrogen. So it's not difficult, is it? But let's look at this little graph here. This is a graph of ovaries running out of follicles or estrogen, and you can see that even before birth, a female fetus is already losing follicles in the ovaries. And then there's this sort of slippery dip all the way down through puberty and the most fertile years, down to around 37, and that's when fertility, because of the loss of the eggs in the ovaries, starts to decline rapidly. And when the ovaries completely lose all those follicles here, we hit the ground here around 51 at menopause. So just to be specific again, menopause is about losing eggs and estrogen. That fall in estrogen results in all of the symptoms of menopause, all of them. And that fall in estrogen, as well as the symptoms, which we'll go into in a bit of detail, actually leads to other negative health effects. So we get increased tummy fat, and none of us like that, increased risk of heart disease, increased risk of diabetes, and a dramatic fall in bone density, and then that leads to osteoporosis, fractures. So it's not actually just the symptoms. And even the women who appear to get through menopause easily without symptoms may be silently having problems with increased risk of their heart and their bones deteriorating. So what's all the controversy about menopause? Menopause is finally, it's only, decades down the track, having a renaissance, and so it should. 100% of women who live to midlife are going to go through menopause. So 100% of the population will go through it, and 80% will experience some symptoms. Not everybody has such severe symptoms that they want or need treatment, but 80% of women do experience symptoms. Menopause, there's this thing that's saying that menopause is natural, so we don't need to treat it. Menopause is natural, it's a normal physiological event, but its symptoms and its health consequences can be really debilitating in some women. What's been the problem? The problem is, some of you might have heard of it, the Women's Health Initiative trial, which was a big trial about 25 years ago now, which basically stopped the world taking the best treatment. The HRT or MHT, HRT are the same thing. Menopause hormone therapy is the same as HRT, because in that trial, old formulations were given to the wrong women for the wrong reasons, and then the research was inaccurately reported. Now, what that did was it stopped the whole world taking HRT, but the really big thing was as well, it stopped all the research into women's health. We're now 25 years behind, and it's only just gathering momentum again now. I've just spent last weekend in Melbourne at the International Menopause Society meeting. It was the biggest meeting they've ever had. There were 2,700 people there, and you can really see this interest finally in women's health research again. But you know what? We've lost 25 years, and some women have lost that time in their lives because they weren't offered the correct information or treatment, which is just incredible. I think, just to be clear, when we're talking about menopause, as I've said, menopause is just that final period. That's when the ovaries really have run out of eggs. In Australia, the average age for that is 51 years, but normal can be anywhere between 45 and 55. So it's a big scope there. Now, this perimenopause thing, I've got here 4 to 5 years, but you know, in some women it can be up to 10 years before that last period. that's when the periods start to become irregular and the symptoms start to happen and the estrogen levels fluctuate wildly and widely. And I'm going to go into that in a bit of detail. And let's just look at what I've said. So if I've said that a normal menopause could be as young as 45, and some women are getting symptoms at least 5 years, if not longer, before that, that means that young women in their late 30s could be in normal perimenopause. And unfortunately, they're being given a brush off and being told, well, you know, you're too young to be in perimenopause. Not so. That is just not the case. Early menopause is a different definition. That's when you go through the last period younger than 45, between 40 and 42. You might have heard of premature ovarian insufficiency. That's when you have that final period under 40 years. So there's a lot of different definitions, but maybe just think about the perimenopause, because that's that many years before the final period, and it's often difficult to diagnose. So these are the symptoms, and I won't go into them in a lot of detail because I think mostly you're aware of them, but around the perimenopause, it's interesting, and I'll show you why in a minute. You can actually get symptoms of high estrogen and low estrogen because the levels are fluctuating. So mood changes, sore breasts, bloating, headaches, and periods all over the place. They're common. At nearer to menopause, but still in perimenopause, hot flushes and night sweats. Now they're the same thing. It's called vasomotor symptoms. I don't know why they're called hot flushes in the day and night sweats at night. They're the same thing. Poor sleep. Now the sleep can be because of the hot flushes, but in some women they're getting poor sleep even if they're not experiencing flushes. There's this thing called formication. It's not fornication. Formication is when you get this feeling like there's little insects or ants crawling under the skin. There's no rash to see, and if you go to a doctor who doesn't quite know about this, they'll think, you know, what's wrong with her? But it's really classic of menopause, and we need to remember that. Now, joint pains. This is about you, Cherry, and the thing is that in some research trials, although we focus on the hot flushes, in some research trials, what I call the old lady feeling, and I don't mean that trivially, it's a big deal, and in some research trials it is more common than the hot flushes. So it's both joint aches and muscle pains. And what it is that you get up in the morning and, like Cherry Lee described, you think, God, I must have done a huge workout at the gym yesterday or been to Mount Lofty yesterday, except you didn't. So it doesn't tend to cause very specific and localised things. So if you've just got a shoulder thing or just a hip thing, it's not likely to be menopause, although those things could be worsened by it. But it's this all-over body ache thing, like you're recovering from COVID or the flu. So it's really dramatic in some women. Mood irritability, we'll get to mood stuff in a minute. Fatigue, as Cherry, and low libido, which is multifactorial at any age, but certainly can be part of this. And then later in menopause, all of those things can continue, and we add in vaginal dryness, the urogenital symptoms, and Sonia, our pelvic floor physio, is going to speak to us about that later. And I've already mentioned the osteoporosis and heart disease. Doesn't sound good, does it? You know, menopause after it, if it is properly treated, means that the next 20, 30 years of your life can be fabulous, but you've just got to get the right information through this time. So what are this? Why you rabbit on about hot flushes? Some of you may be experiencing them, some of you may get that just a little feeling of warmth, but when I talk to women who are really suffering from that, I say, well, what do you do when you get night sweats or hot flushes at night? So they say, well, I go to bed and I feel fine and then get to sleep, and 20 minutes later I wake up in a sweat, the bed is soaking, I get out of bed, I change the sheets, I have a bit of a shower, I get into bed again, it takes me 30 minutes to go back to sleep. By then they're sleeping on a towel because they don't want to have to change the bed again. And then an hour later it all happens again. Now, I don't know what we think about how much sleep anybody would get if that was happening. I mean, a lot of women feeling basically quite trashed in the morning, so it's not restful sleep. Now, if that's just happening for a week or two, or even a month or two, maybe we could cope. But the average time, which we will get to in a minute, the average for women is 7.5 years. That is a long time to be without refreshing sleep. It means a lot, and these flushes can impact every area of life. Women can decide that they're going to leave relationships, they're going to stop work, they're going to not accept a promotion. It's not just, it's life-changing for the women in whom it is affecting in that way. And these are the sort of numbers. This is one trial from Australia, from Melbourne, and it found that 74% of women under 55 were experiencing these hot flushes. 30% of them we've classed as moderately to severe. And moderate to severe means it is affecting every aspect of women's lives. Now, other women in the gap there between may still be getting hot flushes and still affecting some areas. It's not that the other, whatever, 75% don't want or need any treatment. But in this severe section, it is impacting everything, and women can't function. This is the really scary thing. We used to say, if you're going to go on HRT, take it for the shortest possible time, just a year or two. Problem is that 42% of women over 60 are still getting hot flushes, and 33% of women over 65 to 79. And I mean, I see quite a number of women, and basically flushes are going on forever. And as I've already said, 7.4 years in this trial. That doesn't mean everybody goes that long. I mean, some women may only have symptoms for 4 years, some for 20 years. And no blood test will tell us which women they are. I'm not going to go into these other factors today, only because I haven't got enough time. I'd be here all night. But I just want to make a point. Although I've medicalised it, if you like, because I think it's important we understand the biology. I've said that menopause is about running out of estrogen. But all of these other factors do come into how you experience menopause. And certainly at the international meeting over the weekend, we had people talking about all of these aspects. They're all relevant and can be differingly important in you. Now, I want to just go through my pet graphs, which some of you will have seen me do before, but I need to do it because I think this business of doing hormone levels, blood tests, at the time of menopause gives a lot of women and their doctors, for that matter, confusion around this time. So in most areas of medicine, of course, we do blood tests to diagnose things, you know, to have your cholesterol diagnosed or your sugar or your whatever else, thyroid. You do a blood test to diagnose something, and you use the blood test to decide what treatment to go on. Hormone blood tests at the normal time of menopause between 45 and 55 aren't just a waste of time, they're positively confusing, and I just want to show you why. So if you look at that blue squiggly line there, I think I've got a pointer here, the blue squiggly line, if you just take that as levels of estrogen, can we see that? Yes, level. So in normal reproductive cycles, you just have a little squiggle up and down. Each time you have a period, the estrogen goes down just a little bit. That's normal. Let's go down here to the bottom where we've got menopause with the last period. I won't use this, I'll just talk to it. And down at the bottom there, this is where you basically, it's not absolutely zero estrogen, but it's minimal estrogen then for the rest of our lives. So some people say, well, when am I through menopause? Well, none of us, we don't make estrogen again. We don't have any estrogen forever. And in between is that drop of estrogen, the perimenopause. And if it dropped in a nice straight line like that, well, maybe it would be worth measuring. But it doesn't drop like that. It drops like this. And when I draw this squiggly line for all of my patients, when I first see a new patient, suddenly it becomes obvious why periods are all over the place, bleeding's all over the place, the symptoms are all over the place. But I also hope to convince people why blood tests are not useful. So if you look at the first red circle, that's down at the bottom there. That lady might be having hot flushes. We could do a blood test there. We could say, yes, your estrogen is low, your FSH is high, you're in menopause now. And so the woman thinks, well, great, I'll stop using contraception. Trouble is, the next month, there is a rebound here. There's an egg pops out, and we've got a Woman's Weekly front page baby saying, my doctor said I was menopausal, and now I'm having a period again. Well, they're obviously talking rubbish. If you go to the third one, not the high one, the third one along, which is at approximately the level of the normal levels of reproductive years, this lady could come in and say, well, I've had 2 years of fluctuating symptoms of hot flushes. My doctor's done 15 different hormone blood tests. And if you happen to go to the pathology place just when you have a normal cycle, you could have had 2 years of symptoms and be told, you silly woman, you know, your hormone levels are normal. Go and have some counselling or something. Now that is completely useless, and it's also really unhelpful, obviously, to be told that. The other thing that can happen, if you look at the circle in between there, in the early perimenopause, the feedback from the ovaries isn't perfect, and sometimes the ovaries are sort of doing a last hurrah, and they give a sort of big squeeze under, they don't literally do that, but they release a lot of estrogen, and for a brief time, at a time you're running out of estrogen, you can get high levels. And if you go to the alternative doctors, they will say, oh, this isn't menopause, you've got a high estrogen, that's why you've got sore breasts. True, that is why you've got sore breasts. But they say, well, this isn't menopause, this is something called estrogen dominance, and you need progesterone to balance it. That's not true either, because a week later, down you go again, you've got the hot flushes again. So I hope this graph, once I do that, women understand why it's just not going to be helpful doing hormone blood tests. The hormone blood tests don't tell me whether you're someone who's going to last 7 years, 2 years or 20 years of flushes. It doesn't tell me what treatment to give you, but it can waste 2 years of your life. So I really think that is important, and I hope I've made it clear. You know more than most doctors now. Let's just look at what you should expect at a menopause consultation. It's not difficult, but I think it's worth you knowing what you should expect there, and maybe go in with something like this, dot points. You do need to be updated in your routine women's health checks. Just make sure you're up to date with your smear tests and the mammograms. But this is the big one. Whatever age a woman is when she goes through menopause, there is an increased risk of heart disease. So this is an opportunity to refocus on all of the risk factors. This is even if you're not having any symptoms at all, you're still losing estrogen and increasing your risk of heart disease. And I think this was made very clear over the weekend. We had a huge number of talks about women's increased risk of heart disease going through menopause, and the fact that it's not recognised, because women have different symptoms to men when they have heart disease, and so they don't do as well, in fact. No hormone tests. We'll talk about contraception in a minute and bone density. And if you've just had those basic things done, and you'll notice I haven't put in any blood tests there, you may need your cholesterol done or something else if you are looking at that heart risk a little bit further. So what can we do for menopause symptoms? It is worth looking at these lifestyle changes, but they are really to look after your general health. It is not to do with reducing your symptoms, because you could be, I think this is really important, women with Cherise type symptoms could be told, you know, you just go to the gym more or less, or go and do Pilates or something, or whatever, or do some meditation. Those things are good for your general health, but they actually won't make a difference to your symptoms. And again, I think that's unfair to women, because they can be doing all the right things with lifestyle, healthy lifestyles, and still feel rubbish. So I really think that's important. I've said that menopause is about running out of estrogen. So it's not rocket science, is it? If you run out of thyroxine and you've got thyroid disease, you get given thyroid hormone back. If you run out of insulin, you've got diabetes, you get given insulin. If you run out of estrogen, you get estrogen is the correct treatment. So that is HRT. It's the first line treatment. It's always been the gold standard. It's just that trial really put a problem under everybody for a very long time. And any woman who hasn't got contraindications, the reasons why she shouldn't take it, should at least be offered it. Some women don't want to take HRT and some women can't, and there are other options. So it's not the only treatment, but it's the umbrella one, because it's the one that will help symptoms and it is the one that will help bones. Indirectly, it will also help heart disease risk. It can be used just for osteoporosis prevention and treatment. So in some women, they've got no symptoms. We hate them though, don't we? Because they make it look easy. Nevertheless, sometimes if women say, look, they've just got mild symptoms and they're not sure if they want to do HRT, which is completely fine, I'll get a bone density. And if their bone density is very low, it may be they would want to consider some HRT just for the bones. The non-hormonal treatments, I'm not going to go into in detail, but I'll answer questions about them. We used to just have, and when I mean non-hormonal, I mean prescription ones. We used to have ones like antidepressants and gabapentin, which do work for hot flushes. but we now have a game changer in that the first time in the world we've got a drug, and I will name it because it is the only one available. Normally I wouldn't use drug names, but it's called fezolinetant. It's something called a neurokinin 3 receptor antagonist, and you'll have to remember that to get out the door. And its drug name is Veoza, V-E-O-Z-A. It's the very first time we've had a non-hormonal drug, works in the brain, which is where hot flushes come from, and it treats hot flushes. What it doesn't do, it wouldn't help you, Cherie, because it doesn't help the joint aches, doesn't help the osteoporosis risk. What it's doing is if your main symptoms are hot flushes and you can't sleep because of that, it's good for that. So it is a game changer, though. It was talked about a lot in Melbourne over the weekend. And out of all of the non-pharmacological treatments, the two that actually have good evidence for working cognitive behavioural therapy and medical hypnosis. And again, I haven't got time to go into that, but they do work if you've got the patience to do that. These things do not work for symptoms, and I'm deliberately putting this up. Please bear in mind that some of these things are really good for health, but they just don't work for the symptoms of estrogen deficiency. So certainly all of the herbal things, vitamin E, unfortunately yoga and acupuncture, of course they could be good for other things, I'm not saying they're bad, but they're not going to help with hot flushes. Paced breathing and even exercise does not help hot flushes. It may make you feel better and tolerate the flushes better, but it's unfair to yourself to think that if you just worked harder at all of this, it would help. It doesn't make a difference. I've got just this one slide, and I thought it might be more useful to circle back to HRT later. Of course, I'm very happy to talk about it in intense detail, but this is one slide on MHT. How do you work out whether it's worth the risk? The main risk of starting HRT is getting a blood clot. That sounds terribly serious, doesn't it? And it is. That happens with tablets of HRT, not with the patches and the gels, and I'm sure you've heard of people using patches and gels of estrogen. The reason we go through the skin with the estrogen is because it does not increase your blood clot risk. Even if you are someone who takes tablets of estrogen, the risk is very small. It's just not nothing. And so some women who are low risk for that are still happy to take that very small risk. It's no different from when they were younger and they were on the pill, which is a tablet of estrogen, or when they were pregnant, when they had very high levels of estrogen. So some women have been through, they've had 4 babies, been on the pill for 20 years. I'm quite happy to prescribe tablets of estrogen for them. But you've got to bear in mind that that's the main risk. We'll talk about breast cancer in a minute on a different slide. It's not a no risk, and the studies show that the absolute risk is very low. And with the modern HRT, you've really got to be on it for at least 5 or maybe 8 years. It depends which research trial you look at before that increases. So we've got time to play if you ever wanted to try it. And although the cardiovascular risk was purported in that trial, the WHI trial, to be a risk, we know it's a benefit for women under 60. So that was false reporting. And I got this slide. This is taken from only 2 days ago at the International Menopause Society meeting. This is Dr. Gemma Figtree, who's a cardiologist in Sydney. She is fantastic and really talks about cardiovascular disease in women in a really terrific way. She put this slide up, and I do think it's worth bearing this in mind. In terms of this, none of us want to get breast cancer, I know that, and 1 in 7 of us as women will get breast cancer. But 1 in 4 of us will have a heart attack. And she put this slide up, and I think this is really worth looking at, that as women think they're going to die of breast cancer, not heart disease, but women actually die of heart disease. So I think I'm just trying to put this in perspective. I don't want to minimise breast cancer, but neither do I want you to we need to be scared of our hearts, not our breasts. Let's put it like that. And we'll go further. I've got this infogram which you can get from the British Menopause Society. I just go through this in a tiny bit of detail, but I'm more talking about the lifestyle risks here. What this has got here is it's showing that in 1,000 women aged 50 to 59 over the next 5 years, 1 in 7 of them are going to turn up a positive anyway. That's our risk of breast cancer, just being girls and getting older. Can't take that risk away. If you add in the WHI hormones, which is a synthetic progesterone, the second line there with the extra 4 women, the 4 little mauve women there, shows the increased risk with the old hormones. Interestingly, the next line with the reduction with the 4 little green women shows the reduction in breast cancer if you're only on estrogen. What I really want you to look at is this section down here. And it's not that I'm not minimising the risk of hormones, but I think this is where we, again, need to get it in perspective. 2 glasses of wine a night, this is very sad, 2 glasses of wine a night increases our risk of breast cancer more than any HRT. I think we need to remember that. You can see smoking has got 3 little people, so that's about the same as HRT. And sadly, this very big increase, which you can see in the second to bottom line, is when people are overweight, and that is a significant risk. The reduction underneath that, this is where exercise does play a part in reducing our risk of breast cancer. So I often say to women, if we're going to start HRT and you want to continue it for a long time, we may be slightly increasing your risk of breast cancer. That's if you want to stay on it for 7 or 10 years. But let's get you feeling better, and then let's focus on these other things here, and we may actually come out ahead. If we can, in feeling better, you'll feel more like eating better, exercising more, doing all those sort of things, reducing your alcohol. So I hope that that's putting it a bit more in perspective. And the weight gain at menopause, I thought I'd better put this up because I talk to every single woman that I see. Every single woman that I see, whether she's a tiny little person, average people, bigger people, whatever, everybody complains of weight gain and menopause, and the particular things, thanks Sonia, is about tummy fat. I think it's important to know that it happens to everybody. Women on HRT also put on weight. Women on HRT tend to put on less weight than women not on HRT, and it's less on the tummy. And that's how it helps to prevent diabetes and heart disease. So just to get it clear that if you go on HRT, you're doing it at a time when you're gaining weight, and it's not the HRT. So new rules for HRT. As I said, we used to say use it for the shortest possible time for whatever. It's just no good doing that. The symptoms are lasting. So now the new rules are that there is no set minimum or maximum duration for using MHT. That we do think you should have a yearly review and individualise it with someone who knows about hormones. And I'll just quote from the North American Menopause Society. All of the major menopause societies have statements like this now, that hormone therapy does not need to be routinely discontinued in women aged older than 60 or 65 and can be considered for continuation beyond age 65 for persistent vasomotor symptoms, the hot flushes, quality of life, prevention of osteoporosis after appropriate evaluation and counselling. So I just wanted to be clear. I get a lot of women sent to me and they're told they have to come off it after 3 years or 5 years. It's just, whoever's telling them that is not up with the latest research, sorry. Quick graph on osteoporosis, just to make it clear. This is a DEXA, it's called a bone scan that you can have to look at your bone density. The blue part of it in the graph there is normal bone density. The age is along the bottom, and up to about 50, all of our bones stay about the same. And then you can see the slippery dip that happens at menopause. Everybody, the whole population loses bone density. The trouble is that at the bottom there, about 70, that's when the government says we can have a bone density, when we're 70 or we've had our first fracture. Now, personally, I want my bone density checked before I reach the bottom of the slippery dip. So I do offer to women, if they can afford it, to have one done. If they're on HRT, it's not so essential because the HRT is protecting the bones, but it can be part of that decision-making process with your GP. Because these are the facts about osteoporosis. Again, 1 in 3 of us will have an osteoporotic fracture, 1 in 6 women will have a hip fracture, and that MHT, HRT, preserves bone and prevents fractures. So I think that's an important one to throw in. And this is obviously important for women who aren't having any symptoms at all. So I've just put up one slide about menopause at work. We could do a whole topic. There was a lot in Melbourne about menopause at work. Australia's a little bit behind, but we're going to hear Senator Smith talk about the fact that we're finally getting our parliamentarians involved and this business of you know, the majority of women around the age of 50 are actually still in work, and we are seeing that many women make work decisions about resigning, about not taking promotions and this sort of thing because of changes in their situation with menopause. So I think it is really important to recognise it, that it's an issue. Mood changes. This again could be a whole lecture. Menopause, as you know, is a window when a lot of stuff is happening in life. You've got older parents, younger teenage children, partners, who knows what they're doing, and then you're at the pointy end of your career. So there's a lot of other stressors going on. I just want to point out that although menopause isn't a time of depression specifically for women, so you don't need to be frightened of that, but nevertheless, if you've had hormone-dependent mood changes in the past, postnatal depression, PMT, you are a bit more vulnerable than the next person when you go down the slippery dip and lose estrogen, bearing that in mind. And the other thing is, it doesn't take much to find stupid cartoons of, you know, mad women with axes and stuff at menopause. Some women, when they get mood changes, are teary or depressed. Some are anxious, but some of them get this, what we call dysphoria, real anger, road rage stuff, going from 0 to 100 in a millisecond. And the trouble is that, you know, some people deserve a serve out there, basically. But nevertheless, I think women like to feel they're in control of it, and sometimes they're not. They're doing it when they go, oh, I wish I hadn't said that. So I think being aware that that can be a unique presentation. I've got one slide on the mood, cognitive changes, the brain changes. We had the world expert Pauline Mackey speak to us in Melbourne. Big problem is that all the research in women's brains and cognitive function, guess where that went for the last 25 years? And she is the world expert and is just starting again. And she made the point that we know that women aren't sleeping, they've got low mood, they're changing levels of estrogen. Yes, it will affect your brain function, but we haven't actually got good research just to show that HRT directly affects brain function. It appears to if you fix the flushes and the sleep, but we do not have the good data that we can give you because of that backwardness that's happened. I'm going to leave this area to Sonia in a minute, the whole urogenital atrophy, that's the down below stuff. She will talk to you about that, but just bear in mind it's really common, and we've got very good vaginal estrogens that can treat it without any risk. So I think that's important. So I think, have I got to 5 minutes? Or good, okay. I'll slow down slightly. Just maybe repeating myself here, but these are the myths and misconceptions that I see commonly and that can hold up the diagnosis and the treatment, giving you evidence-based treatment. So I think I've made my point. You don't need hormone blood tests to diagnose menopause. Let me put it like this. I teach the medical students at Adelaide University, and if they do hormone blood tests on women between 45 and 55, we fail them. Just saying. So you can repeat that somewhere else. You can start HRT before you've stopped your periods. A lot of women are told, oh, well, because you haven't got to that final period and then a whole year beyond that, which is what you've got to do, by then you could have had, what, 5 years of symptoms? You've got to wait for all that time before you can even start HRT. Not so. You can start HRT well in, at the beginning of perimenopause, and I often find that in my experience, mood changes and cognitive stuff are some of the first things that start to happen. You don't have to stop MHT after a certain number of years. I think I've made that clear. I am saying here, look at lifestyle improvements at menopause. That's not to treat the symptoms, but it is to look at general health. A lot of women, because of all of the lack of sleep, come and one of their first things they say to me is, I think I've got dementia. And I can reassure them that mostly it is certainly nothing to do with dementia, but you've got to remember that brain health is heart health. So all of the things you can do to look after your heart, if you are worried about dementia later, I think we all are, all the things that protect your heart will protect your brain and protect you from dementia. One thing here, don't think if you've had breast cancer, there's nothing to be done about menopause. We don't give MHT to women who've had breast cancer, but there are safe non-hormonal treatments that we can use. And that also applies to women who just don't want to use MHT. Not everybody does, and that's completely understandable. We do have good evidence-based treatments, and have a yearly review. I don't give somebody a script and say, see you in 10 years. I mean, a yearly review, because research can change, and what your body might change. So when I've talked about information, I'd recommend the Australasian Menopause Society. The Gene House is good as well. This is the main academic website in Australia. This is the one I belong to. I've been president of this. We've got information pamphlets, and because we've discovered nobody wants to read anything, we've got YouTube videos, and they're really worth looking at. We've got information about, there's many more than that. Finding a menopause doctor. Sherry talked about this. This is one of the harder ones, I do know that. On the AMS website, we've got a drop-down thing that says find a menopause doctor. If you click on South Australia, we've got all the doctors who are members of the AMS in South Australia. They don't have any certification, I'm afraid, so we can't guarantee they're the best in Adelaide or whatever, but nevertheless you can at least see that they're gynaes or endocrinologists or GPs that at least have said, I've got an interest in menopause. They're not going to say, not my area, because they're part of the AMS. So that's worth looking at. And I think this is my final slide. So I just want to summarise. Menopause and the post-menopausal era, you know, that 30 years beyond, it begins 1 year after the final period. It lasts for the rest of your life. And menopausal symptoms affect around 80% of women, and only, for lots of the reasons Cherie has talked about, 1 in 3 seek help from their doctors. The symptom duration is at least 7 years, although 40% of women still have flushes and sweats in their 60s. All of this is happening to women in midlife and mid-career. And women will spend over 1/3 of their lives after menopause, sometimes 1/2 of their adult lives, in a low estrogen environment associated with adverse effects on bone, heart, and mental health. There are safe hormonal and non-hormonal treatments available, but in the studies we've done, the majority of women are not accessing them, not due to their own faults, due to all the things I've talked about. So I think that's my last slide. And I'm happy to take questions later, maybe, or whatever you want. Yeah.
It's Dr. Jane Elliott. We will give you a chance to ask questions, so hold on to those if you've still got some that you need to get a bit more detail about anyway. But as Jane said, we've got another person who would like to present tonight and help you in one specific area of this. Sonia Schaaf-Billig is a pelvic floor health specialist. She's a physio, I should say. She's chair of the SA branch of the Continence Foundation of Australia. She's also a member of the Adelaide Pelvic Pain Network, which is a multidisciplinary group of health professionals dedicated to helping people with chronic pelvic pain, and she is associated with pelvic floor health. Sonia, come and join us. Sonia Schaaf-Billig.
Great. Now, hello, good evening everyone. Can everyone hear me? Yes, great. Thank you, Sonia. Thank you to Jane and Dr. Elliott and to Helena for asking me to talk to you this evening on menopause and pelvic health physiotherapy. I don't have much time to go through quite a bit of information with you this evening, so I'll jump straight into it. What I'd like to do is just briefly explain what pelvic health physiotherapy is, because I have lots of colleagues who work in this area and we're all really busy, but I have at least 2 or 3 patients a week who tell me I had no idea this sort of physiotherapy existed. So I'll briefly go through that. And then I'll talk through a pretty typical patient example that I come across of someone who is exhibiting menopausal symptoms. I'll talk through the bladder, bowel and prolapse symptoms, and I will offer a very big apology to you all and say that I won't be covering libido or sexual dysfunction. Something had to give, I could not include it, but I'm very happy to talk about it during question time. Yes, always next year, yeah, that's right. Okay, so pelvic health physiotherapists. We are all standard physios, but we've done extra training to understand bladder and bowel dysfunction, pelvic organ prolapse, pelvic pain. Now, at the risk of offending people, we still use the term women's health and men's health, and we just haven't found a suitable way of changing this to be more neutral with our terminology. Women's health is more focused on the antenatal period and men's health clearly for men. And I just have to explain that up until a few years ago, physios assigned female at birth were helping people assigned male at birth with their pelvic floor issues. And only in the last few years we've had a couple of physios assigned male at birth who are actually working in this area now. So this is fantastic. We also have some physios who predominantly work with children and adolescents. For most of us, we don't cover all of these areas, and we specialise in a few. So where I work at Pelvic Floor Health, I see lots of people with pelvic pain, bladder and bowel dysfunction and pelvic organ prolapse. What to expect at an appointment with a pelvic health physio? Expect to sit down and talk a lot. We have the luxury of time with our patients. I spend 60 minutes with them for an initial consult and 30 minutes for follow-ups. And as you'll see with the patient example that I'll go through, we have to talk through a whole lot of different bits and pieces about you, so we do need the time. We may ask to do a pelvic floor muscle assessment, and that gives us a whole lot of valuable information, but you can decline that assessment if you would prefer, and we would make a really well-educated guess on perhaps what you may need to start doing, and then check in with that and continue to work with you on that. We will most likely put together a home program for you that is hopefully well suited to you, which doesn't just involve pelvic floor exercises, but it would involve perhaps some modifications to some lifestyle factors as well, and that's what I'll go through right now. So a patient example, a pretty typical patient, let's say she's 50 years old, she's had a couple of vaginal births, and she says she's going through menopause. It's been maybe several months since she had her last period. She comes to me and she reports that her symptoms are a gradual onset of very intense urgency to go to the toilet to empty her bladder, and perhaps leakage sometimes with that, and that's only come on in the last few years. She may also have some leakage with coughing or sneezing or impact exercise. Maybe that's been happening for a bit longer. Regular constipation now over the last few years, that wasn't really a part of her life previously. And from a prolapse perspective, she's starting to feel a little looser through the vaginal area, maybe noticing a bit of a small bulge at times. So from a pelvic health physio perspective, if we look at the first lot of symptoms, so from an urgency perspective, the statistics suggest that about 55 or so, somewhere between 40 to 60% of women going through menopause or the perimenopausal period will have issues with bladder urgency and leakage. So that's a really big number, and it's really changeable. From a physio perspective, what we want to look at, what I'd like to find out is what is happening from a fluid perspective. So I find bladder diaries are really, really helpful. They let me see how often the patient might be going to the toilet, how bad the urgency is, what her volumes are that she's drinking and passing as well. It's really, really helpful. I would like to assess the vaginal area to assess for dryness, and there's only so much I can do with that. As in, I can't prescribe medications at all, but I can use my eyes and assess pretty clearly. We have first-line evidence, really strong evidence to suggest that oestrogen therapy is really helpful from a dry vagina perspective. If we bring urgency into the picture, oestrogen will absolutely nourish and plump up the vaginal area. It will also transfer over to the urethra and help to keep it shut a little bit better, if I say it that way. So it can really help with urgency issues. And I would also like to see what the pelvic floor muscles are like, because we've got, again, excellent evidence to support using good muscle strength to keep us dry and to calm urgency. So treatment-wise, for vaginal oestrogen, I would send the patient back to their GP to talk about vaginal oestrogen therapy. I would start my patient on a pelvic floor muscle exercise program involving long holds and maybe short, strong, fast squeezes. Bladder training, I find, is a really lovely way of calming the urgency down. A TENS unit can be useful, and this is a very happy lady holding her TENS unit in one hand, a magazine in the other, and she's got little electrodes on the inside of her ankle. That's where one of the nerves that innervates the bladder is quite superficial, so you can get to it pretty easily there. And I don't know that anyone is entirely sure how TENS works, which is transcutaneous electrical nerve stimulation, but it can work for some people and can be really helpful. Fluid modification is another one. So some patients are, with the best intentions, drinking way too much and affecting their bladder control. Other people are leaking so much they don't drink anything, they make their urine very concentrated, and that's very, very irritating. So we have to work with that as well. Bowel issues, the regular constipation. So the statistics on this in menopause was a little bit elusive, I found, but we know that constipation worsens with age, and there are definite links with stress and tension. From a physio perspective, what I'd like to look at with this patient is how often is she emptying her bowel. So a bowel diary, really simple, really easy to record in. I would get to see how often this person is straining, how often she's passing emotion, and any laxatives or any fibre supplements that she might be taking also. Fluids play a big role in this, so I would like to see if this patient has reduced her fluid intake to help her leakage, her bladder leakage, but that has then made her stool a lot firmer and harder to pass, so that plays a role there. I'd like to get a bit of an idea of fibre in the person's diet, but I'm not a dietitian, but I can make a few conclusions from that. And perhaps this person might have a prolapse or something that's actually obstructing the stool from moving through the anorectal area, and we can do things about that. So treatment absolutely would involve checking fluids, and we can do that with a bladder diary. Fibre supplements can be really, really useful. Stool softeners can be really helpful as well. Positioning on the toilet can be a total game changer. Adopting more of a squatting position on the chairs that we sit on the toilet. Breathing, relaxation strategies are very, very helpful. Exercise will start that conveyor belt of the colon really starting to move. And if there is a prolapse, and a particular type of prolapse that might be stopping the stool from passing through, then providing some support to that or learning how to work with that is really important. So we've covered two of the three issues that this person has reported, and already you can see there's actually a whole lot of work we can do with these people, which is great. Prolapse, I've put up some anatomical images onto the screen, and I don't know how helpful it is, but if we look at the top right image, that's an image of the bladder dropping a little bit further down and in, more than it should be. Bottom left is the back passage dropping in a bit, and that can be where stool gets a bit stuck, or the uterus can make its way down. So these are the three different types of prolapse that can occur and tend to be perhaps a little bit more noticeable during this time of hormonal change. So the statistics are almost a little bit scary. 1 out of every 2 women who've had a vaginal birth may have some form of a prolapse, but you can relax a bit because only about 10 to 20% are symptomatic. And of those people, again, we can make some really lovely changes. If you've had or you have a caesarean section, that does not protect you completely from having a prolapse. I'll just pop that in as well. We know it's due to the changes in connective tissue that can occur, and so just carrying the weight of the baby can be enough for some people. And there are lots of other things that contribute to prolapse: chronic coughing, chronic heavy lifting, chronic straining. So from a physio perspective, what I'd like to look at is the health of the vaginal area, because if you've got dry skin, it's not really skin, but it's like skin inside the vaginal area that's herniated a little bit, so it's really pressing up against more dry skin, that's just uncomfortable. So being able to nourish the area and hydrate it with vaginal estrogen or a non-estrogen based vaginal moisturiser can be really, really helpful and make you more comfortable. We have ways of assessing prolapse. They're very easy to do, and you can do it during a pelvic floor muscle assessment. So I'd want to look at that, and I'd want to look at the strength of the pelvic floor muscles, because we have a lot of good evidence to support strengthening the muscles to really support particularly a bladder prolapse, but we can assist with some of the others as well. So treatment, pelvic floor exercises, we want to take those muscles perhaps from being a little bit droopy to being nice and toned and strong, like Arnold Schwarzenegger is how we talk about it sometimes. Vaginal oestrogen, very important. Vaginal pessaries, there are a range of types that you can use. They're little silicone devices that you can insert into the vaginal area and hold up what wants to sit a little bit lower. And again, a real game changer for comfort throughout the day. People can go and play their netball, they can go and look after their grandkids, they can stand around at work all day and be really comfortable when previously they couldn't. We would give particular advice about exercises that are suitable, the types of daily activities that you do. There are lots of little knacks, little tips and tricks to learn. A big no-no is straining or constipation, ideally never having to cough again and whatnot, but you know that's really difficult, so having some good strategies to being able to support that area with good muscle strength and pessaries. Right, so very quick talk through a lot of information just then. The take-home messages, I think, if you're ever thinking of talking to or going to see a pelvic health physio, is know that you will have time to tell us your story and we will listen to you. We do have a pelvic floor muscle focus, but that's not the only part of it. There's good evidence to support good muscle strength through a whole range of issues that may arise, but also evidence for changing some lifestyle factors that I've gone through also. And I find, yes, Jean Hales is a wonderful organisation to gain more information. So if you're interested, you might want to jump on that website and you'll get some great answers to some questions, and the Continence Foundation of Australia is very, very helpful also. I'll leave it there for tonight.
Thank you so much, Sonia. Stay here if you can. Oh, I just had to suppress a groan getting up there, but I think I'm in company that understands that. Dr. Jane Elliott, can I ask you to come up again as well? Should we get some chairs for these? You've both been standing for a long time. Maybe they can at least sit down as we start to think about the questions. You've received a lot of information tonight, and I know it can be a bit overwhelming, but you may have come here with particular questions, or maybe what you've heard has raised some questions for you. We're going to have a couple of people with microphones in the aisles. Hopefully they're getting ready right now. If we can pass those microphones out there. And we've got questions already coming. So I'll say one up the top here and you're second while we get those microphones to you.
Thank you.
I'll put you out. Just put your hand up if you would like us to ask a question. Maybe we can give a second microphone here and they can go straight into it. Go for it.
Thank you for the talk. And I have a question for Dr. Elliott. Maybe my case is a bit specific. I have a family history of breast cancer, grandfather and mother. And I wonder if I can or cannot take estrogens either as an HRT or at least pessaries.
Okay, I guess maybe I'm going to answer your question. We don't want to give absolute advice to individuals tonight just because I'd need an hour with you to make sure that we knew all the aspects. But I'll talk in general. So we did get some useful information from the WHI trial because it was the biggest, this is the one 25 years ago, it was the biggest trial ever of HRT. And it did show, interestingly, that a family history of breast cancer is not what we call a contraindication. It's not an absolute reason to not have hormones. So whatever the family history is, and it depends on the details of when your father, I think it was, and so whoever got breast cancer, depends on their ages and other aspects of ovarian cancer in the family, that can change a patient's individual risk and puts them perhaps at whatever increased risk. Then there's the individual risk of HRT, which, as I've said, is low or nothing for the first few years. They don't multiply each other. And this one doesn't mean that you can't take it, but it does depend on how big the first risk is as to whether somebody would want to have any more risk at all, even after a few years. So certainly I get women coming to me who say things like, you know, my mother got breast cancer at 75 and I've been told I can't take HRT. That is just not true. But it does need to be weighed up individually for each person, but as a blanket thing. But some women might say, well, look, it's still going to worry me the whole time, even though you've said it's not medically a risk. And I think this is important, that if that's the case, then maybe we would talk about a non-hormonal treatment. We'd also talk about what sort of different screening, different sorts of mammograms and ultrasounds you might have to make sure you were getting optimal screening. Does that make sense?
Thank you. Yes.
Middle here.
Yes, thank you. I've got I can hear my own voice. I have a question for Dr. Elliott. Is there an interaction between hormone replacement therapy and endometriosis?
Well, yes, in that endometriosis is stimulated by one's own estrogen each month, and that keeps it going. And if you go through menopause and lose your estrogen, then endometriosis does tend to settle a bit because of the lack of estrogen. So then if we go and give it back, HRT can keep that going. And so it's, again, not what we call an absolute contraindication at all. Lots of women with endometriosis use HRT. But we do keep a close eye on whether we're stimulating it. We might we'd probably try to keep the estrogen low and the progesterone a little bit higher to sort of monitor that. So there is that relationship. Menopause fixes endometriosis, if you like, but only if you're not going to go on HRT, which may apply to some women. You know, it's lucky if they don't need, maybe they're one of the women who don't have many symptoms, and that would be ideal.
And I guess it's about symptoms of one and the other interacting.
It is. There's no perfect answers in medicine, so we're weighing it up. And people often say to me, you know, do I believe in HRT, or would I give someone with endometriosis? I mean, I'm a GP. Nobody ever asks me if I believe in diabetes treatment or if I believe in asthma treatment. So what I believe in is giving women information, and I figure we can make our own minds up. If we are given the correct information, then I step back, because some people might go, well, I don't want to do I've had such a rotten time with endometriosis, I don't want to do anything to stimulate it. And then we'd work hard with non-hormonal treatments. Yeah.
I actually have one more question, if that's okay. How do you know when you've reached an optimum level of the hormone replacement therapy? Is it a complete absence of some of these things?
It's a good question.
Can you improve it more?
You can't get super fabulous. I mean, I'd like to say that, but no.
We thought you were a miracle worker, Jane.
And thank you for asking, because in the same way that we don't use hormone levels to diagnose menopause, it sounds as though you understand, we don't use hormone levels to say you're on the right treatment. We basically balance it a bit between if women are getting maybe sore breasts and they're feeling a bit like Dolly Parton on hormones, that's a bit too much estrogen. I don't try to get rid of every last hot flush. I think menopause is basically going on underneath. And I think if women are just getting the occasional one, I say, so what's happening now? You're still getting hot flushes? Yes. I'm getting an occasional one once a week. What do you do then? I just turn over and go back to sleep. I figure that's it. And then you sort of know you haven't overdone it. So it's not the complete absence of symptoms, no. What about one for Sonia?
Hi, thank you very much for the talk. My question is, I heard when we could start having HRT,
Yep.
I heard that you don't need to stop at certain age, but what's happened, like in my case, where I was having HRT and then I reached certain age and they told me you need to stop now, but I still have the symptoms. And for example, bone density is really a problem for me at the moment. So can I rejoin the HRT, or is it just too late?
Again, a good question. So basically, I'm sorry you were stopped. That's the first thing. That was the wrong advice. Unless you did have medical reasons for stopping. Otherwise, as I've said, there is no stopping. So this is happening a lot though, and women will come to me and say, well, I took it till I was whatever, 56, and then somebody said I had to stop it because it was 5 years. If the lady is under 60 and doesn't have significant, what we call vascular problems, and that really means you haven't had a stroke or a heart attack or a blood clot. It's as simple as that. I don't mean, you can still have blood pressure that's treated, high cholesterol, you know, normal, those sort of things. You can restart under 60, and the current guidelines say that you can start HRT or restart it in the absence of significant risk factors within 10 years of menopause or under 60. Now, I've just been to this big medical conference, and if anything, I'm not saying we will do this yet, they haven't changed those guidelines, but they are saying that we should be treating women more on biology, not chronology. So biology, so if we get someone of 62 who's been told all of that time, she's had hot flushes now for 12 years, but she's figured out that she'd like to use some hormones, if her biology, which means she hasn't had a heart attack or a stroke and she's well, they are starting to say we might consider the lower doses, the through the skin, which is lower vascular risk, because she might be healthier than someone of 54 who's smoking, high blood pressure, has already had a heart attack. So I think you will start to see over the next few years, we will start to even shift that extent, we'll extend it again. Yeah, it's interesting. Yeah.
Can I just add to that? You were mentioning about breast cancer and how that impacts hormone treatment if someone's already on HRT. Should you get breast cancer after you start HRT, can you then swap to a non-hormonal therapy?
Oh yes, you can definitely swap to a non-hormonal therapy.
Okay, because you shouldn't stay on HRT after that, should you?
That is one rule at the moment, is not to stay on HRT. Although for somebody mentioned vaginal estrogen, unless you're on what are called aromatase inhibitors, which are the sort of big guns for treating breast cancer, then most specialist oncologists, cancer doctors will let you still use vaginal estrogen for those symptoms, so they can still see Sonia and get all that bit fixed, even after breast cancer. Is that the message you're giving and getting? Yeah.
Definitely, yes.
Yeah, I think that's important, isn't it? Because if you're using those pessaries, it really helps to have vaginal estrogen, doesn't it?
And certainly also with the topic that I didn't discuss, the sexual dysfunction side of things that can happen during this time of life, absolutely, that's a very important part of management. No, we're first contact practitioners. You can just call up and come. Yep.
We need a microphone.
Microphone down here. Let's have some hands up so we can pass the microphones around. Oh, sorry, you have your question while we're waiting.
Oh, thank you.
Go ahead.
Thank you both for an informative night. Just wanted to make a comment. I'm pretty lucky and got into menopause in May, and I think I only really had perimenopause for a year. But I've been suffering for something else for several years. I would call it's stridor in medical terms, coughing and wheezing. I was diagnosed after seeing a new doctor who sent me to a respiratory doctor who said see an ENT. And it's called subglottic stenosis, narrowing of the airway. Very rare, serious condition, 2 in a million, but they say it comes out in menopause. I'm just wondering, and kind of has.
You've taught me something. I've not heard of that, I'm afraid.
No, not many people have because it's so rare.
Yeah, so I don't know about that.
But
Did they suggest any menopause treatment for it?
Sorry?
Did the ENT suggest any menopause treatment for it? No, okay.
I'm fairly lucky. I don't get many symptoms.
No,
just the ache in the hips, and I had the Achilles for 6 months getting out of bed, but that's stopped now after 6 months. And a hot flush, I don't know, very rare.
Yeah, so
I'm lucky, but I've got this autoimmune disease instead.
Okay, yes. I think we do collect things, don't we, as we get older, and that's one of the things we do weigh up. That's why it takes so long in a menopause consult to weigh up all of the different things that we do need to take into account before we don't just, well, I guess some people do just get handed a script for HRT, but I find that unless I've explained it in a lot of detail, in the same way that Sonia explains things in a lot of detail, rightly so, women just won't use it, and that's correct. You've got to understand what's going on, haven't you, for things to work, don't you think?
Absolutely, yep.
Yeah.
My question is for Sonia about preventative or proactive healthcare in terms of pelvic health. You talked through some cases, but what about getting onto things before stuff goes wrong?
Sure. So learning how to contract and relax your pelvic floor muscles would be a great start. And if you're not sure how to do that, there are actually, Jean Hales has some information, the Continence Foundation of Australia has some information about that if you don't feel like you need to come and see a physio to do it. And these days, post-COVID, there's probably so many YouTube videos out there with people talking you through how to do this. So, while we say don't hit Dr. Google in this instance, you'll probably be okay. So certainly making sure your pelvic floor muscle strength is good. Now, if you go through the motions and you are really not sure if you're doing it correctly, absolutely come and see someone to set you on the right track, because it's really hard. Every other part of our body we can see when we're working those muscles, but pelvic floor area, really difficult. It's all tucked inside of us. Being really conscious of your fluid intake. So I would just go out on a limb and say, for people who are drinking, who think they should be drinking in excess of 3, 4, 5 litres of fluid per day, please rethink it, because it's a really big challenge on the bladder. And yeah, it can lead to quite a few issues. From a bowel perspective, eating a good diet and getting on top of constipation or poor bowel control. I didn't go into leakage or urgency issues with the bowel, but that's another issue that you potentially could come across. If you have any concerns, go and see someone who may be able to help you. Stay healthy. Understand how your body works. Ask questions.
Thank you, Sonia. Have we got one more question? Oh, we've got a couple. Let's try and whiz through them quickly if we can. Okay, we'll just move those microphones around. We've got a few more minutes.
I hope everyone's contracting their pelvic floor.
Yeah.
5.
Hi. I'd like to ask a question about mental health and menopause, which is something that I've struggled with for a few years now. I'm one of those people who had to give up work, even though I was on MHT. And in the last 6 months or so, it's been discovered that I was no longer absorbing estrogen through the patches. And for a point there, I was looking at some really strong medication, which I didn't want to take for depression and anxiety. But within about 2 or 3 weeks of using gel, I've kind of come lifted, not quite there yet, but I'm getting there. And so I'm really interested on any studies that are being done about the brain and menopause. And also, I'm pretty much, well, I think my GP says I'm in menopause. So one of my things is also, how long can I stay on? Because I don't want to go back to that again,
Well, as I say, I would need to, have an hour with you to say, but that question was asked quite a bit in Melbourne, and I'm not being frivolous. Several of the world experts, when they were asked how long people should or could stay on HRT, several of them said, well, 3 days before you die. So there really isn't a stopping point now. It doesn't mean you would keep on it forever. It means that every few years maybe you'd try a slightly lower dose. Goes against intuition, but as we get older, a lower dose of hormone will do the same job. So then you might find in 5, 10 years, you think, oh, actually, I'm on the lowest dose. Maybe I will have a look underneath and maybe I don't need it anymore. But some women need it forever. And then it's a continual weighing up of the risk versus benefit. I think, as I said, the whole problem of cognitive brain function it hasn't been properly researched. But in terms of mood, it has been. In fact, at conferences, there is always debates about things where there is a bit of contention, and we had a debate between Pauline Mackey, who is the world expert in cognitive function, and Professor Jayashri Kulkarni, who's probably the world expert in mood and menopause in Melbourne. And they debated about if women get mood problems at perimenopause, should we offer them hormones first or antidepressants first? And nobody quite won the debate, and it actually came out as I said, anyone who, they said if there'd been previous history of any hormonal dependent postnatal depression, PMT type stuff, definitely estrogen first. And Pauline Mackey was very keen that the antidepressants were offered first. I suggested that perhaps, given some women do need both, some women need both things for mood problems, and yeah, exactly. This is really common, and I would suggest that instead of us playing on high doctors and going, well, you've got to take this first, I would suggest that what we think about is, say, I would offer both to women and go, well, this is what, and maybe we'll have to try both. Which one would you like to try first? But some women, quite a lot of women, will end up on both at this time, and that's perfectly reasonable.
Up the back. Yes, no, I'm looking at you.
Hi, Jane. I was just wondering whether you'd like to make a comment about testosterone in all of that, as well as estrogen.
A comment. It could be an hour-long lecture. Okay. Testosterone in women is important. It doesn't, though, drop suddenly. Remember my slippery dip? It doesn't drop suddenly at menopause. Our testosterone drops slowly over time, and anyone's testosterone at 40 is half of what it was at 20. So there's not a sudden drop, and it doesn't precipitously drop and need replacing. Some women notice the drop, though, more than others, particularly women who've had a premature menopause or a surgical menopause. If the ovaries are cut suddenly, those young women notice that. It is really important if testosterone is used. Australia is the only country in the entire world that has a testosterone replacement for women, a TGA approved one. And I am going to say the brand again because it is the only one that anyone should be using. It's called Androfem Cream. So it's a cream used once a day. Unlike hormones, the estrogen hormones, it does need monitoring with blood tests. So if you go to either the Jean Hales or the Australasian Menopause Society, we've got pamphlets on it. Professor Susan Davis from Melbourne is the world expert, and on the AMS we've got her speaking about testosterone. She spoke in Melbourne on the weekend and made it absolutely clear that we should only be using testosterone for low libido, I'm afraid, not for mood and energy. Doesn't work according to proper evidence.
Now, Sonia and Dr. Elliott, I've got a question for one of our online listeners today who's viewing, and I'm not sure you'll be able to answer this, but hopefully with all your connections through the work that you do, this non-medical question might be something that you can help with. This person says, I work in a very physically challenging job that is becoming increasingly difficult for me due to my menopause symptoms, I should say, sweats and flushes, joint pain, exhaustion. Are there any support services available specifically for women who need to transition out of their current employment and into employment that is better suited to managing symptoms? I have found I am not eligible for a lot of services because I am a sole trader and not unemployed, and yet I don't have the financial resources to take time off to retrain in a field that would better support my needs as a menopausal woman who cannot take HRT. Does a service like this even exist? Any information?
I don't know of a service like that. I think I'd turn it around a little bit. If she's got such severe symptoms, I think finding someone who can treat her with a non-hormonal treatment, and that will widen her options enormously, I would say.
Her experience is that those have been hit and miss at best. Do you think that these can be helpful for her?
Not knowing her history, I think it's worth pursuing it. However, menopause in the workplace is important, and there's a huge document called from Professor Martha Hickey from Melbourne. If you just put in MIPO, M-I-P-O, I can't remember what it stands for, but anyway, it's a big document about menopause in the workplace and what workplaces can do to help support women. I don't know whether that would be worth her considering giving to her workplace or looking for something like that. There's certainly no organisation I know of that would
I
do
agree,
that.
sadly.
Yeah.
No, I don't, no.
We will be hearing from the Senator in just a moment about some of the workplaces, but that may also be one of the areas that perhaps has fallen through the cracks, even in these recommendations from my memory of them. Helena, you've got a final question?
I do. I'm just going to show you the slide you put up there,
yes,
the multiple factors influencing menopausal symptoms, and I can't leave tonight without asking you about ethnicity and culture.
Yes. Okay, so ethnicity is interesting in the way that it can affect menopause. So what we know, and I've got to try and remember the stats here, what we know is that different countries have menopause at different ages. So I am trying to remember this because I did actually speak on, only very slightly on this in Melbourne. In Asian and Caucasian populations, menopause is around 51, but in Hispanic populations and in people from developing countries, it's actually nearer to 45, so that changes. And if I think about my slide over here, certainly in Western countries, then hot flushes are more the major symptom, but certainly in some Asian countries, and particularly in Japan, definitely Sherry's symptoms of the joint aches and muscle pains are more common. So it does change when women go through menopause and the symptoms you get depending on the countries. And there was, in Melbourne, every different country had their own menopause session in which they presented their own stats. It was really, there were about 30 different what are called CAMs, which are the Community Medical Menopause Associations from different countries, and they all presented on their version of menopause. It was huge in terms of showing the differences. Yeah, so that's my full knowledge from right now. Yes.
We're going to have to wind up soon, but I don't want to leave anyone. If there's one more, is there one more question? Yes, okay, final. Go for it.
I'm just wondering, we talk about how find a good doctor. Is there something happening in the medical training in the universities, in the doctors coming out, where they're actually going to now get appropriate training? I mean, they learn about everything else. Are they not going to learn about this moving forward? Because I feel like even younger GPs are like, oh no, it's all right, my mum was fine.
I know, it is. I think, well, one of the nice things in Melbourne was, for the first time, I saw tons of young doctors, and it hasn't been the case up till now. They have felt, there is some, I'm a GP, so I don't want to, put down GPs because it's hard to be across everybody's specialties. Nevertheless, GPs couldn't say, well, I don't do heart disease or I don't do hypertension, but they have been able somehow to say, I don't do menopause, and it isn't appropriate.